ovarian torsion mimicking a malignant tumor. This case was done with a 35-year-old grand multipara who presented at 26 weeks of gestation with complaints of abdominal pain, swelling, and weight loss of 4 months duration. She was admitted with a fasting volume of 24, which dropped to 15% after transfusion of 6 units of blood. She was co-managed with the hematologists who were planning for a bone marrow biopsy to determine the cause of the anemia. The provisional diagnosis then was hepatomegaly with anemia recurrence. The husband was about to procure 7 units of blood when I was requested to review the patient. She was in painful distress and pale. Abdominal examination revealed a huge tender mass on the right. It was clearly separate from the uterus. It appears more like a tumor sign, obstructed level. However, the uterine side was compatible with the gestational age. Now let's look at these 2 videos. Patients. Here's a pyramid, fetus, the lesion, not ascites here, not the heterogeneity of the lesion, hypoechoic areas here, hypoechoic areas, not this, but fluid in the Moris's pouch, the gallbladder, the liver. So you can see that the mass is clearly separate from the liver. Not the differential epigenicities. Hypoechoic, hypoechoic, not these multiple areas of hemorrhages. So again, this video, the fetus. Lesion. Not the cyst, not this follicle, not the hypoechoic area here, hypoechoic area. So not the mixed echogenicity here. So not this large right ovarian lesion, the liver, and not the size of the mass. You can see it's closely applied to the liver. Again, not the differential echogenicities of this mass. So there is a short video. I applied pressure here to see if this mass move away from the uterus. And apparently one can see that it's not adhered to the uterus. So you can see that. Then it is fluid, it's trickled down here, and you can see clearly the demarcation between this lesion and the uterus. So apparently there is no adhesion here. So you can please and the color Doppler. Here you can see all this are actually artifacts. The patient was in pain, so she moves, and the fetus also moves. So these are actually motion artifacts. But this one is true color flow, true color flow. So the color flow here is 2. So here's a solid lesion. I imputed all this information into the aorta hardness model. And the result is that the risk of malignancy in this case is about 92%, with the highest risk for stage 2 to 4. But remember that the IOTA models are not validated in pregnancy, but this is the best objective tool available today. And I don't see why it cannot be used in pregnancy, because a solid lesion in the non-pregnant is still a solid lesion in the non-pregnant. Yes, the heterogeneity may change probably because of edema, because of projection, but that would hardly significantly reflects the interpretation. Because here we have a solid lesion in the situs. If we have the same solid lesion in the situs, the risk of malignancy will still be high. What is important is that in pregnancy, the blood flow is increased, but thankfully, blood flow is not part of the IOTA complex model. So, patient have surgery. The finding is a 6.5 kg right ovarian lesion. At surgery, the pedicle was found to be twisted 3 times, and there was no ascites. Now, this is a cross surface raw specimen. These are different aspects of the specimen. Now, comparing the ultrasound image and the cross image, here you can see hypoechoic area, areas of heterogeneity here. Look at the texture here, it's different from this, different from this, different from this. And here, look at these cysts. Here, there's the cysts here with this picking. So look at the heterogeneous nature here, the heterogeneous differential texture here. The cysts here with picking, the cysts here picking. So proper correlation between ultrasound and the cross specimen. So, final diagnosis by the histopathologist, hemorrhagic. Patient made full recovery as associated with Zoom or regular parent activities. Now, having known the diagnosis, but it is not the malignant lesion that we suspected. It is not the malignant lesion as obtained using this model. Now let's review these videos closely and see whether we pick the telltale signs of ovarian torsion. Here, look at this follicular sign. Look at this edema. Look at the peripherally displaced follicles here. Look at the dermatostroma. Look at this follicular sign. So these are features of ovarian torsion. Again, here, look at the peripherally displaced follicles. Look at the heterogeneous hypotesta. Look at the follicular sign. So these are features of ovarian torsion, which is mistaken, both subjectively and objectively. So when I got that information, I went back, I retrieved this from my book. This was a case of ovarian torsion. You can see this is the surgical specimen. Look at the torsion here, look at the edematous ovary, and look at the ruptured cyst here, predisposed to torsion. Here is dermatostroma, not the echogenic area here centrally, and the follicular size here. So if you look at this patient, the same thing. Look at the heterogeneous echotexture, look at the ovarian edema, peripherally displaced follicles, look at follicular ring sign. So all these are features of ovarian torsion, which was not picked initially. And this the noise below is saying that the eyes can only see what the man suspects. So if you are suspect, we have made the diagnosis of ovarian torsion rather than suspecting a malignant lesion or its attendant consequences, although even the adness model may have matters of this.